So this is a 69-year-old man who presented in the summer of 2016 with nocturia, and that triggered PSA, which happened to be elevated around 50 or so, and a large prostate on the digital rectal exam. So he underwent a prostate biopsy, which confirmed adenocarcinoma of the prostate, Gleason 8. And he also got staging scans with bone scan and CAT scans, which revealed some nodal involvement and no bone metastasis. So in the context of nodal involvement in the diagnosis of metastatic prostate cancer, this patient was started on androgen deprivation therapy in August same year. He initially got a very nice serologic response. PSA dropped beautifully, but after several months, PSA started to go up again. And around a few months later, he developed some fatigue and some mild back discomfort, which triggered restaging scans. The scans at that time revealed, 2 new bone metastases. And so this patient was considered for enzalutamide. Enzalutamide is an androgen receptor target therapy. The way it works is basically blocks the androgen receptor, and is one of the life-prolonging therapies available, and we commonly use. Basically, the approval is based on 2 large phase 3 trials in the metastatic setting, with Prevail and Affirm data that both with survival benefits. So we can use enzalutamide in the metastatic castration-resistant setting pre and post chemotherapy with taxanes. So when we have a patient that progresses despite androgen deprivation therapy and he develops metastatic castration-resistant prostate cancer, enzalutamide is one of my favorite options because it's an oral therapy, because it improves survival, because it leads to serologic response, and delays time to new disease in the scans. PSA at time of enzalutamide initiation was 25. Patient got a PSA response on treatment with enzalutamide, but then PSA started to rise again. So response lasted for approximately a year or so. And then restaging scans done a year later revealed further bone metastasis. So he was failing enzalutamide therapy and was considered for treatment with radium-223 Xofigo. Patient was started on radium-223 and completed 6 cycles of therapy for 6 months in total, treatment per month basically. He was doing quite well, and with overall PSA stabilization, but approximately a year later he developed new clinical symptoms, mainly with fatigue. He felt beaten up, and restaging scans revealed lymphadenopathy, which was new, as well as new liver metastasis. At this time, the decision was to offer him chemotherapy with docetaxel, which he has started, and with good clinical and serologic response so far. When we have a patient with metastatic castration-resistant prostate cancer, we have a few things that we take into consideration when we select a treatment among all the treatments available, right? So, one of the points is actually improved survival. We have 6 life-prolonging therapies, and where chemotherapy with docetaxel is included, as well as radium-223, enzalutamide, etc. So when we pick a treatment in this patient, when we consider him for docetaxel, the goal was mainly to control his symptoms. We have to regain control of the disease that's clearly progressing despite androgen deprivation therapy after radium-223. The second goal is, try to improve his survival. We know disease is progressing despite he has seen, androgen deprivation therapy, enzalutamide, radium-223, so 2 life-prolonging therapies for CRPC disease. And so the hope is that with chemotherapy we can regain control of disease and make him live longer and keep his quality of life as best as possible.